All right, let's go through these 3 chapters real quick. The first one is hydration and oral health. So we have a couple of different types of hydration issues. We have those who can eat, or I'm sorry, can drink, that are capable of accessing and consuming fluids, but they just don't know what adequate intake is, or they may forget to drink. They may need education and verbal reminders. We have those who cannot drink. They are physically incapable of accessing or safely consuming fluids. This may be physical dependence or swallowing disorder. This may be, we may need things like thickened liquids, sports bottles, sippy cups, swallowing evaluation, things like that. We have those who won't drink, and this is the highest risk of dehydration. This is somebody who is capable of consuming fluids safely, but do not want to. This is typically because they have a fear of becoming incontinent, or they have a low cognitive ability and consume limited amounts. And then, of course, we have our end of life. This is when our terminally ill individuals have hydration patterns that differ from normal, and that's normal with our end of life care. Okay. So, of course, all of these things are talking about us trying to see why dehydration is occurring, because it does have the highest mortality rate. It is a reduction in the total body water within us. And there are a bunch of risk factors that come along with dehydration. Our age-related changes, our medication uses, our laxatives, our diuretics, our ACE inhibitors, our psychotic medications, they all impact our hydration level. Any kind of functional deficits, the inability to pick up a cup and use it, the inability to swallow, dysphagia, things like that. Communication or comprehension problems. They may not be able to say that they need something to drink, or may not have it available to them. Oral problems like mucosa issues. We see this sometimes with like our cancer patients. They have radiation therapy, chemotherapy. It causes those oral ulceration, so it could just be painful. Dysphagia, delirium, dementia, hospitalization, and then of course our diagnostic procedures that require an NPO status. Other things that can impact it are illnesses, which is going to be like when they're sick and they have that anorexia because they're sick. They have diarrhea, fever, vomiting. Those are all going to increase our risk for dehydration. Okay. So, signs and symptoms of dehydration. This is pretty much everything you learned in MedSurg 1, except for you cannot use skin turgor as a sign of dehydration because of how their skin has changed with aging. So things that we may see are going to be those dry mucous membranes within the mouth and nose, those furrows on the tongue, that black lines on the tongue, speech, not being able to talk, rapid pulse, weakness, dry axillae, those sunken eyes. Those are going to be all signs of dehydration. So maintaining hydration. We want to make sure that we are providing fluids consistently throughout the day. An older adult should receive about 1,500 mLs a day. We should be giving about 75 to 80% of our fluids at mealtime and the remaining at medication times to make sure that they're having that. We want to make sure we're offering varieties that a person may prefer. We want to make sure that we're planning for our at-risk individuals. Make sure that we have modified containers based off of their capabilities to hold and drink using straws, things of that nature. We want to make sure fluids are accessible. We want to make sure that there's filled fluid pitchers, fluid stations, beverage carts, so they don't have to ask. They can just go get if they want. Of course, we want to make sure we're encouraging their families. We need to document I's and O's very, very well. We want to make sure we know our how much is in each of our specific containers so that we know how to document it accurately. So as far as rehydration, so this is someone who's dehydrated and we need to get them back to a hydrated status. This is going to depend on the severity. For less severe, we can use oral rehydration. This is just pushing more water by mouth, things like that, popsicles, water, juice, anything like that. For more severe dehydration, we can use intravenous therapy. With that, we do worry about hyponatremia and fluid volume overload, so we got to make sure we're monitoring for those signs and symptoms, especially if we have IV going. Another piece that we have is the HDC. HDC is hypodermolysis. This is when this is an alternative to intravenous fluid for someone with mild to moderate dehydration. This is where a subdermal, so subcutaneous needle or device that's placed in the subdermal packs of the body, very similar to like an insulin pump, and it is providing fluids. This cannot be used for severe hydration because it cannot give any more than 3 liters over 24 hours, but it does help for those who don't quite need the IV fluid resuscitation. So promoting our oral health, we want to encourage annual dentist exams, especially those who have dentures. Make sure that we're brushing and flossing twice a day with fluoride and mouthwash. We want to make sure that their dentures fit well and are cleaned regularly, that they're maintaining a adequate fluid intake. We're avoiding tobacco, limiting alcohol, and eating a well-balanced diet. We want to make sure that we can adapt a toothbrush if manual dexterity is impaired. So those are things that we're going to look at for promoting our health, for promoting our oral health. So xerostomia, that's just our dry mouth. One thing is that we do not want to use lemon glycerin swabs because they're gonna, with that dry mouth, because with that decreased salivatory flow, we're not going to be able to produce enough saliva to make the lemon glycerin swabs work as they normally would, and it will actually promote bacteria growth. So we do not want them to have lemon glycerin swabs. Okay. Our risk factors for oral cancer, of course, we have tobacco, especially the smokeless tobacco, alcohol, oncogenic viruses, especially HPV, and then being genetically susceptible. So big thing is that early detection is key. So we need to look for signs and symptoms of swelling in the neck, lumps or bumps, white or red speckled patches in the mouth, sores on the face and neck, unexplained mouth bleeding and tenderness, hoarseness, sore throat, change in voice, cough with no no underlying cause, dramatic weight loss, pain in the teeth, things like that. So we need to just be mindful of that because early detection is key for treating oral cancers. So our oral care for our older adults, some things to think about is that those who are 65 or older typically have untreated tooth decay or have already lost all of their teeth. Typically, this is a result of periodontitis, which is that inflammation within the oral cavity. Some reasons for this, especially access. Access to dental care is typically limited and not very cost effective. In our current healthcare system, dental care is deemed low priority and Medicare does not provide any coverage. Very few Americans over 75 years old even have dental insurance. And so this is going to be a reason that they're not having their teeth looked after. Typically, those who have the worst oral health are going to be those who are economically disadvantaged and lack insurance, those who are disabled and homebound or institutionalized. Access to dentists and long hair facilities is very limited because a lot of dentists aren't willing to come out to the facilities. And with some of the equipment and things that are necessary to transport these patients, we may not have them here. May not be able to take them there as easily as we could. So some things to know about this. So our MDS, remember that is required upon admission to a long-term care facility and at different points thereafter. Require information obtained from an oral health evaluation. Federal regulations mandate that annual exams for residents of long-term care facilities be done. Although it should be done by a dentist, a nurse in a healthcare setting can provide oral screenings. So this is kind of how they get around with not seeing a dentist. Some things to think about. We need to know our dental care, our denture care as nurses, especially in the inpatient setting, and education. A lot of times oral and mouth care is neglected as part of daily nursing care. And this is going to contribute to poor nutrition and other negative outcomes such as aspiration or ventilator-associated pneumonia. So mouth care is very critical in preventing these in all areas of patient care. So now we're going to talk about elimination, bowel, bladder, incontinence, things like that. All right, so the first thing we're going to talk about is a healthy bladder and promoting a healthy bladder. So hydration is big for this one. We want to make sure that we're drinking 8 to 10 glasses of water before 8 p.m. Eliminate and reduce the amount of coffee, teas, colas, alcohol, especially before bedtime. Make sure that we are emptying the bladder completely before and after. Urinate whenever an urge occurs. Do not hold the bladder. We want to limit the amount of antichlorogenics and CNS depressants. So remember, our antichlorogenics are going to make it so we have urinary retention. And our CNS depressants are going to decrease the sensation of needing to use the bathroom and needing to urinate. We want to make sure that there is accessible bathrooms so that we have a clear path with good lighting, grab bars, raised toilet seats, and especially if there's difficulty in getting to the toilet. We want to make sure that they're not smoking, getting regular exercise, maintaining an ideal weight, and we want to make sure that they know to seek treatment and talk to their provider if they have any burning, urgency, pain, or blood in the urine. All right, so now we're going to talk about urinary incontinence. The biggest thing is that urinary incontinence should never be considered a normal part of aging, and it does require evaluation and treatment if it occurs. We do have some risk factors for urinary incontinence, such as immobility or functional limitations, diminished cognitive capacity, different medications, smoking, caffeine, dehydration, obesity, constipation, pregnancy, environmental barriers, diseases such as diabetes, stroke, Parkinson's, history of a hysterectomy, poor pelvic floor muscles, history of childhood nocturnal enuresis is going to be a risk factor for urinary incontinence later in life. History of prostate surgery or estrogen deficiency, arthritis, which kind of goes with our functional abilities, and BPH. A lot of times this is going to affect our quality of life and has physical, psychosocial, and economical consequences. So we have different types. We have stress, urge, overflow, functional, and mixed. So stress is where we lose a small amount of urine with activities such as coughing, sneezing, lifting, bending, things like that. We have urge, which is where we lose moderate to large amounts of urine before getting to the toilet, so we can't make it to the toilet. Overflow is going to be a constant urine loss, so basically dribbling throughout the day. Hesitancy starting urine stream and slowing the stream, only passing small volumes at a time. Functional is going to be typically due to a lower urinary tract issue and individuals unable to reach the toilet because of lower urinary tract is typically fine, but it's because the person cannot physically make it to the bathroom for environmental environments. Cognitive impairment, no assistance, belts, zippers, things like that. And then mixed is a combination of more than one, typically stress and urge. So we need to make sure that we are recognizing and analyzing clues to evaluate someone's bladder function. So we're going to use screening questions. Have you ever leaked urine? If so, how much? Have you ever not made it to the bathroom in time? You ever use pads, tissue, or cloth in your underwear to catch urine? Do you have any burning or pain with urination? We may get them to have a bladder or voiding diary, which is kept for 3 to 7 days to see kind of when things are happening, just like any other kind of sleep diary, anything like that that we're maintaining. We want to look at patterns of intake. So we look at, this is more of a diary looking at how often fluids are consumed. We're going to also look at our bowel patterns with this. And we're going to look at history of symptoms, like especially for the urinary incontinence. When did it start? What have you done to try to manage it? How often does it happen? Do things make it better? Do things make it worse? Is it severe? What voiding symptoms are there? Are there any things like pain or blood within the urine? We're going to make sure that we're looking at our focused history, looking at any kind of medications that may be in there, and things like that. Typically, our treatment is going to be lifestyle modifications, such as increased fluid intake, weight reduction, smoking cessation, bowel management, and avoiding caffeine and alcohol. We also will do things like environmental changes, like promoting a continence-friendly environment where there are toileting aids, raised toilet seats, the toilet is visible, there's signage. This is where people with cognitive impairments or visual issues can find the bathroom. And then, of course, there are behavioral techniques such as scheduled voiding, prompt voiding, habit retraining, bladder retraining, and pelvic floor muscle exercises. Right? So some things we can that we can also be leading to, that something that can cause urinary incontinence is going to be our UTIs, our urinary tract infections. And one thing that we need to look at is our CAUTIs, our catheter-associated urinary tract infections. So there is the ABCDE of best practice for CAUTI, and it's going to be adherence to general infection control principles. B, be sure to use a protocol in place to avoid unnecessary catheterizations. C, condom caths or alternatives to an indwelling cath. This could be intermittent, this could be our PureWick, like I said, condom caths, things like that. D is do not use indwelling catheters unless you absolutely must. And E is going to be early removal. We know that long-term catheter use increases the risk of urinary tract infections, which can lead to urosepsis, leading to urethral damage. CAUTIs is going to be one of the most common healthcare-associated infections, and Medicare will no longer reimburse hospitals for this infection. We need to make sure that indwelling catheters, like we said, are only inserted for appropriate conditions, and alternatives must be investigated. Okay, so big things is our CAUTI and our catheterization. So this is, we're going to look at bowel health. So we have our constipation. Constipation is a symptom, not a disease. It's typically a reflection on poor habits, delayed response, or chronic illnesses. A thorough evaluation is going to be important for this. And constipation should not be blamed on age alone. Okay. So a severe complication of constipation is going to be a fecal impaction. This is typically common in incapacitated and institutionalized individuals or those who require narcotic medications. For a fecal impaction, we're going to have to use a digital rectal exam and abdominal x-rays to confirm the presence of impacted stool and to remove as well. We want to make sure we're evaluating our clients for constipation so that we can prevent a fecal impaction from happening. So things like that would be, what's your bowel pattern? How many minutes do you sit on the toilet before you have a bowel movement? Do you have to strain? Do you think you're constipated? Do you have any abdominal pain, nausea, vomiting, rectal pain? Have you had any bowel or rectal surgeries? And what kind of physical activities do you engage in? So of course, we want to look at food and fluid intake. We know our non-pharmacological is going to be our fiber, fluids, and exercise. And then, of course, we do have pharmacological such as stool softeners, laxatives, enemas. Enemas should be reserved for situations in which all other methods did not produce a response, or if we know that there is an infection. Okay, so those are just our things on constipation, and y'all know this. Fiber, fluids, exercise, you know, a lot of medications can cause constipation and things like that. None of that has changed. So now we're going to look at healthy skin. Okay, so some skin disorders that we talk about. We have cirrhosis. This is the most common skin problem. It is extremely dry, cracked, and itchy skin. So when we're looking at an assessment with this, we're going to look at dehydration, nutritional deficits, and systematic disorders and open lesions. We want to intervene by maintaining a more humid environment and promoting increased oral intake because the skin can only be rehydrated with water. Creams, lubricants should be applied. Make sure there's no, it should be, make sure there's no perfumes or alcohol within it because those can be very drying. We can use mineral oil or Vaseline. Those are typically going to be effective. Only use tepid water for bathing, so not hot water. Hot water is going to dry the skin out, and we want to avoid long baths, and we need to avoid daily showers if possible, and advise for sponge bathing because, like I said, these showers are going to, and baths will dry out the skin more. We want to make sure that we can use petroleum jelly for extreme dryness. And then a consequence of psoriasis is pruritus, which is itchy skin. Okay. We have thinning of the dermis that leads to increased fragility of the dermal capillaries and easily ruptured blood vessels is going to be purpura. This is going to be our easy bruising with minimal trauma. You get a little bump and you get a big bruise. We have our skin tears. These are painful, acute, or accidental wounds. Typically, our older adults who are dependent on others for total care are going to be at greater risk. Ambulatory or older adults are second highest. Top cause is going to be equipment, patient transfers, falls, and ADLs. Another one that we need to talk about is shingles. Shingles. It is a viral infection, so it is treated with an antiviral caused by a reactivation of a varicella zoster virus, or chickenpox. And it always occurs along a nerve pathway, and it's typically going to be unilateral. So things that we're going to do to promote skin health is going to stay in the shade, especially between 10 and 4. Avoid sunburning, avoid tanning, cover up with protective clothing, use a broad spectrum sunscreen, make sure we're reapplying it, keep newborns out of the sun, examine your skin every month, and see a dermatologist at least once a year. So some things that we want to look at is our melanomas. So this is a type of skin cancer, and there's some danger signs to remember, and this is another A, B, C, D, E. We have asymmetry of a mole, so this is not regularly shaped, it's more jagged. The border is irregular. The color has color variation, so there's different colors within it. The diameter, it's larger in diameter, and elevation, it's actually lifted up more off of the skin. So those are how we're going to look for melanomas, between that melanomas and like a normal mole or skin spot. Okay. So now we have pressure injuries, which is going to be localized damage to the skin or underlying soft tissue, typically over a bony prominence. Injury can be present with intact skin or as an open ulcer. That's one of the reasons we're calling it pressure injuries now, not pressure ulcers, because they don't have to be open. So most frequently, we're going to see it on the posterior aspects, especially sacrum and heels. We have stage 1, which is going to be a non-blanchable erythema of intact skin. So color changes do not include purple maroon discoloration, because these can indicate more deep tissue pressure injuries. With a stage 2, we're going to have skin loss with exposed dermis. Wound bed's going to be pink or red. It's going to be very moist. With a stage 3, we're going to have full thickness loss of skin, in which adipose is visible within the ulcer. Stage 4, we're going to have tissue loss, where we can now directly see and palpate a muscle, tendon, ligament, or bone. And then unstageable is going to be tissue loss to where damage cannot be confirmed because it has been obscured typically by necrotic skin. So let's look at our risk factors for pressure injuries. Of course, we have prolonged pressure or immobilization, lying in a bed or sitting in a chair or wheelchair without changing position, lying for hours on a hard x-ray or operating table. We see this a lot because of neurological disorders such as coma, spinal injuries, cognitive impairment, fractures and contractures, pain, sedation, shearing forces, so moving by dragging on a bed sheet, impaired perfusion or ischemia, fecal or urinary incontinence is big because of that prolonged exposure to moisture. So that kind of leads into the last chapter that we just did. Malnutrition and dehydration because they cannot produce healthy skin cells if they're malnourished and dehydrated. Certain chronic diseases that have edema, renal failure, PVD, things like that. History of a pressure injury, and a norepinephrine infusion. A big reason for that is that norepinephrine can be very necrotic to the tissue. So we got to monitor that site carefully. Okay. Our nursing actions are going to be eliminating friction and irritation to the skin, managing incontinence and enhancing mobility, and displacing body weight from prominent areas to facilitate circulation. So we all know this. Turning, barrier cream, changing frequently. There is a mnemonic for pressure injury treatment, and it's DIPAMOPI. Debride, identify and treat an infection, pack dead space lightly, absorb excess exudate, maintain moist wound surface, open or exercise closed wound edges, protect healing wound, and insulate, maintaining normal temperature. And that is our chapters 11, 12, and 14.